you're satisfied.
I am.
I hope you're satisfied. You don't understand what this is like.
No, I know it's
I am
hard.
absolutely scared to death.
I know. It's going to be okay, though.
Everybody has said our lives are never going to be the same.
I know, but it'll be better.
And I hope you aren't even planning on going to another ball game this year.
No, your mother is coming in to help us out.
No, Mother came to live with me.
I know, and she's going to help both of us.
You're going to help me too.
No,
this is your baby too, to the best of my knowledge. It's your baby too.
What? To the best of your knowledge?
Yeah, that's what I said.
What do you mean? This is just a great time for you to be telling me this, Marlene. I really appreciate it.
Just what I said.
But we'll focus on the baby and that.
Hey, how are you?
How are you doing?
I'm doing good.
I have been looking forward to seeing you.
Nice to meet you. All right, Mr. Hurst, how are you? I'm Dr. Sessions.
I'm fine. How are you doing?
How have you been?
I have been really, really good.
I have been looking forward to seeing you.
You got here a little sooner than I thought you would.
Well, I wanted to see you.
You look so radiant. She's one of my most special patients.
Really?
I can't.
You can stop it. That's great.
I love having you here. Are you hurting? Are you doing okay?
No, I'm fine right now. Thank you.
Okay, well, it looks like everything's going okay, and I'll come back and see you soon, okay?
Don't be gone long.
All right,
okay?
bye-bye.
All right.
Nice meeting you.
Okay.
Nice to meet you,
Bye-bye.
too.
Bye.
Nice to meet you, too. Don't be gone.
He is precious. He is just
Isn't he
precious.
I'm sure.
I'm telling
sure. You think every man that comes within 10 feet is precious.
Compared to you, yes.
Well, and whatever.
Oh, please,
we'll
just
worry
stop.
about. Okay,
I'm
fine.
hurting right now.
Fine.
I'm
Okay,
having
I'm
a baby.
sorry.
Would you please?
We'll worry about it later. Okay,
Just
I'm
stop
sorry.
it.
Okay.
Stop. I don't want to hear any more of your voice.
What?
No.
Okay. It's okay. It's okay. I'm sorry. It's okay.
I'm Stephanie. We're going to be talking about complications of maternity now. The first thing we're going to talk about is miscarriage, also called spontaneous abortion. Let's look at our signs and symptoms here, spotting and cramping. You see, understand that spotting is common during pregnancy, but the combination of spotting and cramping, that's more indicative there of a miscarriage. So if your client is cramping, complaining of a backache, and spotting, you better be worried about what? A miscarriage. That's right, a miscarriage. Well, let's look at treatment here for miscarriage. The first thing we're going to do is measure HCG levels, and always worry when the HCG levels start to drop. You see, as long as those HCG levels, they're going up, everything's okay. This client's going to be on bed rest and pelvic rest, which means abstinence from sex. And they may need to be sedated, so go ahead and get an IV access if they're bleeding heavy, because they just might need a blood transfusion. The physician may do a dilation and curettage. That's where they go in and remove the remaining products there of conception. Now, our next complication, the hydatidiform mole, or that molar pregnancy. I want you to understand the patho here. This is a benign neoplasm that can turn malignant. It is grape-like clusters of vesicles, and it may or may not involve a fetus, but for our purposes, there is no fetus involved. Remember, we're studying very general terms here. Now, there are times when you have a twin pregnancy, when there is one normal baby, and then the other is the hydatidiform mole. But we're not getting into all that today, all right? But let's look at how all this started. The pregnancy starts just like a normal pregnancy. But what happens is the uterus enlarges too fast. And our signs and symptoms, there are absence of fetal heart tones, bleeding, and y'all, the bleeding that we see, sometimes that may have vesicles there in that discharge, all right? And it's confirmed with an ultrasound. We'll look at treatment here. If it's a small mole, they'll do a D&C. Y'all just empty out the uterus. And we want to teach them, hey, do not get pregnant, and follow-up is very important. You see, they can get pregnant again, it's just not during this follow-up time, all right? If this becomes malignant, it's called choriocarcinoma. They're going to do chest x-rays to determine, hey, has any metastasis occurred there? And HCG levels will be measured weekly until normal, and they are rechecked every 2 to 4 weeks, and every 1 to 2 months for 6 months to a year. Now, we just said, during the follow-up time, the patient is taught not to get pregnant. Now, ask your friend why. You see, when a patient gets pregnant, the HCG levels, hey, they're normally going to go up. But if metastasis or malignancy is present, the doctor will not be able to determine, hey, if the pregnancy is causing these rise there in the HCG level, or if it's a malignancy that's causing that. We move on to our next complication of ectopic pregnancy. Let's look at what it is. It's gestation outside of the uterus. And where does an ectopic pregnancy usually occur? In the fallopian tubes. That's right, in the fallopian tubes. It is confirmed with an ultrasound. Signs and symptoms. What do you think the first sign of an ectopic pregnancy is? Pain. Pain. Now, you see, this client will exhibit the usual signs and symptoms of pregnancy, but then they will complain of pain, spotting, bleeding into the peritoneum may occur. And if the fallopian tube ruptures, then the patient may bleed into the peritoneum, and vaginal bleeding, hey, that may or may not be present. But a very important thing I want you to keep in mind is if a patient has had one ectopic pregnancy, they are at high risk for another. Treatment-wise, they get methotrexate to stop the growth of the embryo. But y'all, here's the goal here. We want to try to save the tube if at all possible. And if methotrexate does not work, they will do a laparoscopic incision into the tube and the embryo is removed. Unfortunately, the entire tube may have to be removed. A laparotomy is done for a ruptured tube or an advanced ectopic pregnancy. Now ask your friend, what are you worried about if the tube ruptures? And here's what you're worried about. You're worried about that they may hemorrhage and need a blood transfusion. They may hemorrhage and need a blood transfusion.
What you think we all named the baby?
I don't know what you want to name it.
I don't know. I'm getting excited now.
Too.
This
We got
is
some
fun.
books at home.
I know, but we need to be deciding.
We'll get somebody to bring the books.
You know
to
what?
us.
What about the name Dr. Patrick Sessions? You know, that's my doctor.
Marlene,
We can name
we
him
are
Patrick.
not naming him Patrick.
Pat?
You just told no.
Patrick?
Nothing with a P. Okay, you just told me some
I
news
just
I
think-
was not
I
expecting.
think that
so
is a pretty
I'm
name,
trying
though,
here.
if it
you
were a
really
boy.
need to work with me.
I think that would be
I'm
a pretty
trying to
name.
be as consoling as I
Okay.
can.
Wait a minute. Shh. Act normal.
okay.
Somebody's coming in.
Hi, my name is Autumn, and I'm the graduate nurse, and I'm going
A
to be
graduate nurse?
taking
What does
care
that
of
mean?
you today.
We've never heard of a
Marlene.
graduate nurse.
Well,
Are you a registered nurse?
I will be.
Well,
will be.
What does your tag,
Well,
Marlene? That says GN.
What
I
does
thought
that-
it was supposed
well,
to
what
say
that
They
orange.
say on TV you're supposed to watch the tags when they come in.
You are, and they're supposed to have their pictures on too. She didn't even have a picture. Are you?
You're scaring
well,
me.
I'm
Yes.
sorry. I have graduated from nursing school, but I haven't taken the boards yet.
You haven't taken NCLEX yet?
Not yet, but I haven't
Marlene,
scheduled.
we-
I
we're
haven't
gonna have to
scheduled.
do something.
And
have
don't-
you taken Hearst Review
Well,
yet?
I had that scheduled too.
She has not. When you have got to take Hearst
Now, don't
Review.
worry, okay?
You've got to- Marlene, she has not even
I'm
taken
certified
Hearst
to take
Review.
care of you. I can take care
She
of
has
you.
not
now,
taken Hearst
I've
Review.
got a
Look, we
preceptor.
really need.
what is a
who is your
preceptor?
preceptor?
Now her name is Miss Thompson, and right now she I think she's at the nurses
You
station.
think?
Well, I
Or
think
is
we
she-
might
is
wanna
she
talk to
here?
her.
Is she here?
I
Yes.
think we might want to talk to her.
Yes, let's meet her. Is she a registered nurse?
She is.
Okay, I
She
think we
is.
would be more comfortable, don't you think?
I would just
Okay.
meet me.
Yeah.
Okay, I'll go get.
This
I'm
is
sure
our
you-
first baby.
I'm sure you're fine.
I'm sure you're good and all, but I mean, this is our first child. We're really a little nervous. Okay.
Okay, I'll go get Miss Thompson.
Please.
Please do, Marlene. She's
My
not
gosh.
even a registered nurse.
I cannot
What are we
believe
gonna-
you let her
wait,
in the
why-
room.
Why didn't we go to the
Why
other
did you
hospital?
let her in the
Why
room?
didn't we go? Why didn't we go to the
Well,
other
we're going to meet Miss
hospital?
Thompson and we'll see.
Okay. Okay.
Okay, placenta previa. Let's look at the patho. It is the most common cause of bleeding in the later months, usually around the 7th month. It occurs because the placenta has implanted wrong. I want you to underline wrong there. An ultrasound will be done to confirm placental location. But how does this happen? What happens here? Well, it happens because the placenta begins to prematurely separate when the cervix begins to dilate and efface. Ooh, so who's not getting the oxygen here? The baby. The baby does not get oxygen. You see, normally the placenta is attached where in the uterus? Up high here in the uterus. That's where we want it to, all right? Now, with the previa, the placenta location, y'all understand these locations. It may be here on the side wall, okay, just called a low-lying placenta. Or it may be halfway covering the cervical os here called the partial previa. Or y'all, it can completely be covering the cervical os. That's called a complete previa. But y'all, no matter the location of the previa, if it's the side wall, a partial, or a complete, the problem is what's coming out first? The placenta, and that's not going to be a normal delivery, is it? Let's look at our signs and symptoms here, placenta previa. Painless bleeding in the second half of pregnancy. Underline painless. There is no uterine tenderness with a previa unless the patient is bleeding. This bleeding may be spotting or profuse, but treatment-wise, for complete previa, y'all, hospitalization is required at 32 weeks until delivery. But why? Why are we going to put them in the hospital? They have to be hospitalized to prevent blood loss and fetal hypoxia. Y'all, if there's not much bleeding, they're going to be put to bed, on bed rest. We're going to watch them real closely, monitor that bleeding, and maybe rule out any other sources of bleeding that may be causing this, like an abruption, okay? We need to be doing things like pad counts, monitoring their blood counts, and monitoring that baby closely. And y'all, we got to monitor for contractions, y'all. If they start contracting, okay, we better hurry up and call the doctor, because is this going to be a normal delivery? No, because the placenta is coming out first here, all right? And the delivery method of choice here is what? A C-section, that's right. Big old stars by this. Do not perform vaginal exams. Very, very important, because you can puncture the placenta and cause an emergency delivery and hemorrhage situation. I also want you to keep in mind, due to those high C-section rates across the country, that a previous C-section is a significant risk factor for placenta previa, y'all, due to that scarred uterus. Fetal complications, preterm delivery, intrauterine growth retardation, fetal distress, and anemia. Maternal complications, hemorrhage, potential DIC risk there. But y'all, good news. Don't we like good news? Good news here is that some previas resolve during the pregnancy, y'all, simply from uterine growth. It just gets up higher there in the uterus. Now let's talk about the abruption. Abruptio placenta. Look at the patho here with me. Is the placenta planted normally here? Yes, it is. Abruptions may be partial or complete. And the important thing I want you to understand here is what happens when the patient abrupts. So let's look at it. The placenta separates prematurely and the patient bleeds. Y'all, this bleeding, it can be external or concealed. And concealed bleeding means, hey, bleeding there into the uterus. And abruptions occur during the last half of pregnancy, and an ultrasound confirms the diagnosis. You see, the separation may be partial or complete, and the ultrasound text, y'all, they can go in and reveal to some extent there the severity of the separation. And severity is based on a scale of 1 to 3, with a grade 3, y'all, that being the worst. But y'all, some abruptions, they're not diagnosed until after delivery when the placenta is examined. So let's look at what causes abruption. These are listed here for you. Motor vehicle crashes, domestic violence, y'all, any kind of trauma there to the abdomen. Hey, previous C-section, but put a big star by these. Rapid decompression of the uterus. Hey, that means the membrane's ruptured, right? But y'all, key associations for abruptions, as their nurse, red light should go off in your head here if that patient reports to you cocaine use, PIH, that pregnancy-induced hypertension, and smoking. Patient reports those things to you, think potential abruption, high risk there. Let's look at our signs and symptoms. Classic sign and symptom for abruption is a rigid board-like abdomen, with or without vaginal bleeding, abdominal pain, and increased uterine tone. Now, anytime you see rigid board-like abdomen, you should always worry that the patient is bleeding internally. Bleeding internally. Why do you think it would be difficult here to palpate this fetus? Because of that rigid board-like abdomen, y'all, that abdomen that's full of blood, all right? Now, how many times during this abruption section have I said rigid board-like abdomen? You got it? Okay, let's talk about treatment. Method of delivery is a C-section. I do want you to underline this rule, and that is, do not perform vaginal exams in the presence of unexplained vaginal bleeding. When you think about abruption, there are 2 nursing priorities that should come to your mind immediately, and that is to manage fetal status and maternal shock.
Well, how much time are you going to get to take off from work?
At least 2 weeks. I'm trying to
2
get more than
weeks?
that, Marlene. I'm doing the
I am
best I
going to be
can.
barely walking in 2 weeks.
We have got to have some income. We are having
I've got
a
to have
baby.
some help.
Well, that's why you called your mother.
I know,
it's
but
not my fault that
look,
you asked her to
I
come.
cannot stay
you
with
know I
Mama
don't
for
like
6
her anyway.
weeks.
That's why I'm gonna go
6
on to
weeks
work.
by
Well, that's
myself.
why she's there.
Please, here.
Well,
Hi, my
Hi.
name's Carol. I'm going to be your nurse.
hi, Carol.
Nice to meet you.
Nice to meet you. I'm
Nice
Mr.
to meet
Hurst.
you.
Nice
Please,
to
I'm
meet you.
hurting.
Hi
This is
there.
my wife, Marlene.
Nice to meet you.
This is our first pregnancy. I'm sure you can tell.
Marlene, my name's Carol. I know you had some concerns about Autumn being
Yes,
a
we
graduate
have
nurse.
concerns because she doesn't look like a nurse to me.
Are you a registered nurse?
I'm a registered nurse. I
Well,
have
her
more than
name's on her
21
badge.
years
Yes,
of
and she's got a
experience.
picture too. They're
Yeah.
supposed to have
And
a
I'll
picture.
be right with Autumn doing everything she does, okay?
Are you sure?
I
Are you
promise
sure?
you that, okay? I promise you.
Because she scared me.
Well,
she did.
She's going to be working directly with
Yeah.
me, okay? All right?
Is that your? Could you come just a little? Is that
Uh-huh.
your picture?
Mm-hmm, it is.
Okay. Okay.
Yeah.
I'm just
Yeah.
checking.
Yeah.
That's her.
And I'll be right with you, okay? We want this to be a wonderful experience and you to be glad that you came to our hospital,
Well,
okay?
I'll be glad
We are.
if
I
everything
think
works
we'll
out
be
okay.
fine.
Okay.
I think
All
we'll
right.
be fine.
Well,
Thank you.
I,
She's
Now, she has a few questions she needs to ask you. Is that okay? Do you feel up to answering just a few
I'll
questions?
try. Well,
Sure.
Okay.
That'll be fine.
I'll
Miss
try
Karen
to
needs us
answer some
more
questions.
Well, I'll help I'll help as much as
I'll
I can.
try.
And if you need
But I
anything at
cannot
all, just
promise
let
you.
me know, okay?
Okay.
I'll be right out
Thank
here,
you
okay?
so
Nice to
much.
meet you.
Nice to meet you too.
And we're glad you chose us.
Thank
okay?
you.
Thank you
Okay.
so much.
Well, she's sweet.
Please.
Well, you talk about Dr. Sessions.
Hi, I see you've met Miss Thompson.
Yes, we did. She is very nice. Very nice.
And she told you I was going to be asking some questions.
Yes.
Well, yeah.
Okay.
But can
we-
you make it fast? Because I am not
Well,
feeling
it's-
We
good.
talked to the pre-admit nurse downstairs.
I've answered everything I know to answer
I mean,
already.
Everything should be on file. Do you have her chart out there?
Yeah, can you just get the file?
Well, I have to I have to
I'm
fill out
feeling sick.
my paperwork. So it's just a few questions.
Demanding.
I know. She.
It's just a few questions. Now, are you allergic to anything?
I've already told him I was allergic to penicillin.
I'm so tired of hearing that question. And go ahead and put down sulfa. Everybody's allergic to sulfa.
Are you allergic to sulfa?
But no, but he said to put it down.
Just put it down, please, so we'll avoid it later.
And going back to the penicillin, what does that do if you take penicillin? What happens?
Well, duh, it gives me a rash.
Okay.
Can you believe this?
And I'm sorry. I'm just trying to
that's okay,
fill
just-
out my
We're
paperwork
just
here.
real anxious here.
Oh, my goodness.
What about the sulfa?
Oh,
what
God.
does that?
Oh, God.
Diarrhea.
Oh, gosh, I can't
Everybody
take it.
gets diarrhea when they get. Please go get somebody that knows what they're doing. Please,
right.
please.
Put the
She is
call
in
light
pain.
down.
Where's the call? They did not even put the call light by the
There's
bed,
something bad,
Marlene.
please,
They didn't
help
even
me.
put the call light. I don't know, sweetie.
Dan,
We'll figure it
me.
out. I'll run
Help
out and
me.
get some help. Just
help
hold
me.
on.
No,
Hold
don't
on a
leave.
minute. Hold on.
Don't leave. Please.
Just
Okay, let's talk about incompetent cervix now. Look at this patho with me, all right? This is when the cervix dilates prematurely and it occurs usually around that 4th month of pregnancy there. This patient reports a history of repeated, painless, second trimester miscarriages. Because I want you to remember this now. Most miscarriages, they occur in the 1st trimester. But I want you to underline 2nd trimester miscarriages here. You see, these patients, they don't have any trouble getting pregnant. They make it through that 1st trimester okay, but it's when they get to that 2nd trimester, they have a miscarriage. Well, ask your friend why. Why does this happen? Well, the reason here is because the weight of the baby is now causing enough pressure there on that cervix, causing it to prematurely dilate, okay? Yeah, because see, in the 1st trimester, the baby just doesn't have enough weight. That's why. Treatment-wise, purse string suture called the cerclage at 14 to 18 weeks to reinforce the cervix. And for delivery, some patients may have to have a C-section to preserve the suture there. Some doctors will clip the suture so the patient can deliver vaginally. But here's some more good news. There's an 80 to 90% chance of carrying the baby to term after a cerclage. That's good news.
Oh, me. Starting to feel sick. Goodness gracious.
Oh, can I help you?
Yes, I need a nurse. I'm getting sick at my stomach.
Okay, we'll be right there, okay?
Okay.
Yes, ma'am, Miss Hurst. Can I do something for you?
I'm getting sick at my stomach.
That sounds like hyperemesis gravidarum.
What? I'm sick at my stomach, okay?
It sounds like hyperemesis gravidarum.
Well, fine, but I need something.
Here.
I'm not about to brush my teeth. I need the garbage can. I'm going to throw up.
Okay.
Girl.
Okay.
Go get me. Can't you get somebody?
Okay.
I want the nurse.
Okay, I'm gonna.
getting sick.
Okay. I'm gonna be right back. I'm gonna see if you've got something for nausea. Okay,
Please,
right now.
go. And bring Miss Thompson back too.
Okay, hyperemesis gravidarum. Let's look at the patho first. Here's what happens here, okay? Just starts like the regular old morning sickness, okay? Ooh, then excessive vomiting, dehydration, starvation, even death can occur. But why? Why does this occur? You see, we always want you to understand why here. This is related to high levels of estrogen and HCG, related to high levels of estrogen and HCG. Let's look at our signs and symptoms. And when you keep in mind the excessive vomiting here, hey, you got these signs and symptoms. What do you think is going to happen to their blood pressure here? It's going to go what? Down. Y'all, they're losing volume here. It's going to go down. So what do you think happens to their H&H, that hemoglobin and hematocrit? It goes up, right? Because they're dehydrated. And their urinary output, what do you think? It's going to go down. It's going to go down, y'all. This patient's dehydrated. Your body says, oh, I gotta help you. I got to conserve volume here. But think about this. Tell your friend what will happen to their serum potassium level. You see, when we normally think about decreased urinary output, we think serum potassium goes up because they're not excreting it. But this person's doing something else here. They're doing what? Vomiting. That's right. And because you have got a lot of potassium in your stomach, the serum potassium is going to go down here simply because of all the vomiting. All right? What about their weight? It goes what direction? Down. And what do you think will be in their urine? Ketones. And ask your friend, hey, why is this patient going to have ketones in their urine? And your friend said, because they are breaking down body fat. Breaking down body fat. So here's how we're going to treat them. This is what we're going to do for them. We keep them NPO for 48 hours. They need fluids, so we're going to give them IV fluids. Ooh, they need about 3,000 cc's for the first 24 hours. They will be getting an antiemetic of choice IV. You know, they've lost a lot of their vitamins from vomiting, so we're going to be replacing them there. But what type of environment do they need? Ask your friend. They need a quiet environment and not close to the nurse's lounge, you know. Not where we're up there. You know what we do? We pop our popcorn and heat up our lean cuisine, all that kind of stuff. Y'all, they don't like to smell food, all right? Oral hygiene for these patients, very important. Protect those teeth there from the acid, from all that vomiting, all right? Do we won't even talk about food to this patient? No, okay? If they even think about food, they get sick. And why do we keep the emesis basin out of sight? Here's the saying, out of sight, out of mind. All right? They need 6 to 8 small dry feedings a day, followed by clear liquids. You see, foods and liquids, they need to be icy cold or steaming hot. You see that lukewarm stuff? That just makes them sick. And they need a very well ventilated room. Now, our next complication, preeclampsia. You're going to see a lot of this. Let's first understand what it is. What's happening here? The client will have increased blood pressure, proteinuria, and edema after the 20th week. Now, I want you to keep in mind, you know, a lot of pregnant women swell, don't they, all right? So edema is associated with preeclampsia, but is not as significant as the blood pressure and the proteinuria combination there. Okay, now y'all know if mom's pre-pregnant blood pressure is not known, then 130/90 is used as the baseline for mild preeclampsia. Signs and symptoms, they will have a sudden weight gain. Now remember, we gave you those normal parameters for weight gain, y'all, earlier in that maternity section, all right? Their face and hands will be swollen. But I want you to ask your friend, y'all, why does that happen? Why? I want you to remember, y'all, these patients are losing protein, and albumin is protein. So their fluid there is not going to stay in those vascular spaces. It's going to leak out there into the tissues. And they start complaining of a headache, blurred vision, and seeing spots. Y'all, hyperreflexia, y'all, that's just increased DTRs, and clonus occur. When you think about these muscles contracting and relaxing over and over again, y'all, you can understand these muscular spasmodic contractions that are going on. Y'all, they may be headed towards a seizure, right? And that's what we're scared of. This tells you as the nurse, this patient may be headed towards a seizure. Now, beside headache, blurred vision, seeing spots, hyperreflexia, and clonus, I want you to write down vasospasms. You see, that's a key word there for PIH, vasospasms. You see, it's the vasospasms that creates the signs and symptoms there. And underline this next sentence. 2 or more pounds of weight gain in a week, watch closely and worry about possible PIH. Always assume the worst. Assume the worst. So you better be checking the blood pressure and the urine for protein. Let's get them better. Let's treat them now, okay? For mild PIH, this is marked by elevated blood pressure 30/15 of their baseline and documented elevations that are 6 hours apart. They need bed rest as much as possible. And what do you think you would increase in this person's diet? Increase protein. Now ask your friend why. And what did your friend say? Your friend said, hey, because their blood pressure is high, that has damaged the glomerulus. And you know when there is damage to the glomerulus, you leak protein, so they get proteinuria, all right? Now let's look at severe PIH. This is marked by elevated blood pressure, 160/110, documented 6 hours apart. These patients will be sedated, hey, to delay seizures, okay? Sometimes Valium may be given, but here your drug of choice is magnesium sulfate. And we've already talked about magnesium. Magnesium acts like a what? A sedative. All right, so magnesium sulfate does 3 really good things here. It acts as an anticonvulsant, it sedates, and it vasodilates. Y'all, that lowers the blood pressure there. When we talk about vasodilation, other good things start to occur, okay? This increases renal perfusion and helps avoid renal failure. Y'all, it also increases placental perfusion, and that's good for our baby, all right? Let's talk about this positioning thing again here. How are we going to position these ladies? We talked earlier about a pregnant lady and how we never want to lay pregnant ladies on their back, okay? Because this causes that full uterus here is going to rise up into that upper abdominal cavity. Hey, that places pressure there on the vena cava. Ooh, so cardiac output is impaired here. And perfusion to the kidneys is impaired. And then perfusion to that placenta of our baby is impaired. That's why always, always, always place the pregnant lady on her side, and preferably the left side. Y'all, it's just a fact. Cardiac output is greater when the patient's on the left side. I want you to also remember one more very important thing about magnesium sulfate. Y'all, so important. I've seen this so many times with patients. Magnesium sulfate is a simple salt solution. Therefore, our fluid is going to be attracted back into the vascular space, out of those tissues. Remember, that's where all the vascular volume is, right? And if the kidneys are functioning well, they will diurese. All that's good. But what if the kidney perfusion is impaired, or hey, this shift just occurs too fast, all right? Then this patient is at high risk for pulmonary edema. High risk for pulmonary edema. Well, our nursing actions for the patient receiving magnesium. Always check for magnesium toxicity every 1 to 2 hours. Your priority assessment includes blood pressure, respirations, DTRs, and LOC. Also, urinary output hourly, okay? Hourly urinary output. But ask your friend why these hourly outputs are so important. Well, y'all, think about this. That's how we excrete magnesium, remember? All right? They're going to be getting serum magnesium checks periodically, usually about every 8 hours is typical. But oh, so important, put a big old star for me by these DTRs. Those are the first to go when the patient is getting toxic on magnesium. Always remember, if magnesium sulfate is used, labor will stop unless this patient is augmented with Pitocin, because magnesium will also cause the uterus to relax. That's why we use magnesium for preterm labor. Let's back up a minute for general treatment now for our preeclamptic mom. A Presolin may be given. If diastolics are greater than 100, then you're going to see this Presolin being used in combination there with magnesium sulfate. But I also want you to remember, y'all, a very classical sign with a Presolin, and that is tachycardia. Y'all, that's just a compensatory mechanism when that blood pressure is lowered. And I also want you to remember this. The only cure for preeclampsia is delivery. Delivery. Now, I also want you to remember that even after delivery, the patient is still at high risk for seizures, even after delivery, especially during the first 48 hours after delivery. You see, they can seize up to 4 to 6 weeks after delivery, but that high risk, that critical time, is 48 hours after delivery. So now let's take care of them. Let's look at our nursing care. They need a single room, a quiet environment, dim lights, and no TV. All of those measures there, you are reducing stimuli. Y'all, this patient is very fragile. Their CNS is irritable. They're at high risk for seizures. But I want you to listen to me for a second. Whether this patient has mild preeclampsia or severe, all right, understand this. What's happening with all this vasoconstriction? Y'all, it's a cyclic effect here. This vasoconstriction causes lack of blood flow to the placenta. Think about that. That leads to less oxygen and nutrients to the fetus. Slow growth of the fetus. Hey, low birth weight, preterm delivery, and immature lungs at birth. You see, additional treatment measures we're going to do is steroid therapy, okay? That betamethasone routinely given to patients who are at high risk for a preterm delivery. But understand this, how does it work, all right? Betamethasone will stimulate surfactant production into the alveoli spaces, and this causes less tension. Hey, when the infant tries to breathe, okay, it's just more effective when there's less tension there in those alveoli spaces. More effective respirations will occur. Steroid therapy is given between 24 and 34 weeks gestation. Now that reduces infant morbidity and mortality. And finally, there is a clinical term that we use to manage these patients, and it's called expectant management. Y'all, the risk of a preterm delivery there to the baby is weighed against the risk there to the mother. The doctor decides when the baby will deliver. But let's look at eclampsia now. What is the turning point from preeclampsia to eclampsia? Ask your friend. It's the seizure itself, isn't it? When they have a seizure. So let's look at their treatment. We're going to monitor those fetal heart tones, watch for labor, and watch for heart failure. Y'all, here's the deal. If you just seized and your blood pressure was high before, now is it even higher? Yes, it's even higher, okay? So you need to be thinking heart failure, stroke, heart attack, renal failure, DIC, HELP syndrome, neurological damage, multi-system organ failure. Y'all, this patient here is headed to the ICU unit. Many doctors will be consulted. But before we leave this subject, I want you to be familiar with some terms here, just in case you see some of this thrown at you on your test, so you're not going to be upset, okay? You'll be more familiar with all this. PIH, that's pregnancy-induced hypertension. Y'all, that occurs after 20 weeks, and there is proteinuria. Gestational hypertension, that occurs after 20 weeks, but no proteinuria here. All right, chronic hypertension, y'all. Patient was hypertensive before the pregnancy, and then chronic hypertension with superimposed pH. Hey, this patient was hypertensive prior to the pregnancy. Hypertension got worse with developing proteinuria after 20 weeks. Now, moving right along to premature labor, preterm labor. First of all, what is it? It's labor that occurs between the 20th and the 37th week gestation there. And treatment-wise, drug therapy, y'all, our objective here, hey, we want to stop labor. Stop the labor with tocolytics such as breathine or terbutaline. You remember breathine, that's a breathing drug, all right? A bronchial dilator, but it also acts as a tocolytic. You've got some important side effects to remember with breathine, and that is increased pulse and hyperactivity. Additional drug therapy would be maybe some magnesium sulfate. Yeah, we just talked about earlier how that relaxes the uterus there. And finally, the mom will be given betamethasone or Celestone IM, 2 injections 24 hours apart. Remember, we just talked about how this works in helping the fetal lungs to mature in case of a preterm delivery. And also, I want you to remember, preterm labor can often be stopped by hydrating mom and treating vaginal and urinary tract infections. These are very common causes of preterm labor.
Hey, girl, I'm in the hospital. Yeah, I'll have a baby tonight. When y'all coming to see me? Soon? Okay. No, I'm not hurt now. I got an epidural and I feel so much better. And let me tell you, these are the sweetest nurses you have ever seen. I mean, I've got a registered nurse and I've got a graduate nurse. And I'm just so tickled with the care that I'm getting. They have just been precious the whole time. It's just been great. Yeah. Hold on one second. This little nurse is in here.
We need to do a check real quick.
Let me call you back. The little nurse says I gotta have a check, okay? I'll call you back. All right, bye.
Okay. We're just going to see how far you're dilated. Okay?
My doctor's only ever been the one to do that.
Well, I can do it. I'm certified. They've trained me to do that.
I know you're certified in something, just don't know what.
Well, I can do it. I promise you. Now, I'm going to let your head down. Okay?
Are you sure you've done this before?
I'm sure I've done this before. You just relax.
Easy for you to say.
Okay. I'll put my sterile gloves on.
Oh. They are sterile?
Yes, they are sterile.
Because the doctor always uses sterile ones.
They're sterile. Okay. Now, just a little bit.
Okay.
Okay, if I can get you to move your hands. Okay, is that hurting any?
No, I'm not hurting now. I got the epidural.
Okay. I'm a brand new nurse and I feel a prolapse cord and I'm going to call someone that knows more than I do.
And that's what you better do too if you want to get a license in the mail. I'm glad you did that. Do you think they're going to come?
They are. They're going to call.
They're so slow to answer.
Well, they're going to call.
Slow. When you need something.
Nurse's station, this is Carol.
Yes, I need a nurse in here. Stat, please.
Stat. I've heard that on ER, and I've been watching the TLC channel where they have the babies and stuff.
Uh-huh.
When they say stat, something bad's happening.
It's all right.
How can you say that when you said stat?
It's okay.
What are you doing?
It's all right.
You are scaring me.
It's just relax.
You are scaring me.
It's okay.
Look what she has done.
I feel a prolapse cord.
Call my husband. Call my husband. He went to Walmart to get him some underwear.
Okay.
Call him. He loves Walmart. Call the preacher. Get the doctor in here. Get Dr. Sessions here.
I'm going to. I'm paging him right now, okay?
What are you doing? I haven't seen you before.
Okay,
Who are they? What are you doing?
We're going to give you the license for the baby, okay? Would you page Dr. Sessions stat,
You are
please?
scaring
Will you
me.
set up for a stat C-section?
You're scaring me.
It's all right.
You're on top of me. What is this for? I can't
Just to make you
suffocating.
better, baby. It's
I'm
okay. It's
suffocating
all
on this
right.
home. This is driving me crazy. Y'all are scaring me.
We're going to go for a C-section.
I said, I wanted to have the baby.
We're not going to be able to
let you have the
C-section
baby.
right
I don't
now.
want to see. Call my husband. He's not even going to be here for the baby.
He will be. We're going to get him here from Walmart. Don't you worry.
What are we all doing? What are y'all doing?
It's all right.
Where's my husband?
What are you doing?
Where is my
I had to
husband?
go get some underwear from Walmart. I got some underwear. I got you some too. What's going on? What's going on?
I'm scared to death.
Oh my gosh. Oh my gosh. What's going to happen? Do you know? It's okay. It's okay. It's okay. It's okay. It's okay. It's all right. It's okay. It's okay.
Good luck on you, lads.
Now, the next thing we're going to talk about is prolapse cord. What has happened? Y'all, the umbilical cord falls down through the cervix. This happens when the presenting part is not engaged and the membranes what? They rupture, okay? Nursing action. This is why it's so important to check fetal heart tones when the membranes rupture, either artificially or spontaneously. Remember, we talked about we want that head well engaged when the membranes rupture. That means that head is down there in the birth canal. Hey, that prevents that cord from falling through. We don't want that cord falling into the vagina or positioning itself in front of that head there, okay? Because, y'all, if this occurs, you're going to see variable D cells and bradycardia there in the fetal heart tones. An immediate C-section is indicated here, all right? But look at that warning. If the cord ceases to pulsate, this is an extreme emergency. Fetal death has occurred. Fetal death has occurred. We always want that cord to at least pulsate just a little bit because then we know, hey, that fetus is getting some oxygen. Treatment-wise, the nurse will lift the head off the cord until the physician arrives, if possible. Y'all, when we're talking about lifting the head, this is a manual lift. When you're doing a vaginal exam, you go in and lift that head up, and the nurse pushes that head up to relieve the pressure there on the cord. And your other staff members, they're rushing around doing all the emergency preparations for C-section. You see, as long as that head is lifted up off the cord, there's blood supply there to the fetus, all right? Now, the patient may be placed in Trendelenburg or knee-chest position, but y'all, regardless, the nurse, you never stop relieving that pressure there off the umbilical cord. We're going to give mama oxygen. We want to make sure that mother's hyperoxygenated so that the blood that is getting to the baby, hey, it's oxygenated as most as it can be, okay? And we want to monitor fetal heart tones. And y'all, do you ever just push the cord back in? No. That's a big, big no-no. And finally, the last thing we're going to talk about today is shoulder dystocia. First of all, understand this. The majority of shoulder dystocias are very difficult to predict. So let's talk about what it is, all right? The fetal head is delivered, and further delivery of the fetus is prevented by the impaction of the fetal shoulder there with the maternal pelvis. You see, the anterior shoulder of the fetus becomes impacted by mom's, that symphysis pubis there. Well, let's look at risk here to our fetus. What's going to happen? Hypoxia, which can lead to cerebral palsy here, and asphyxia from cord compression. Brachial plexus injury can occur, y'all. That leads to Erb's palsy. That drooping paralysis here of an arm caused by excessive traction and stretching. You know, that brachial nerve here is damaged here at delivery. Or maybe even a broken clavicle can occur. Bell's palsy, paralysis of the face, drooping one side of the face here. And it's generally caused from forceps being used. The good news here is that many resolved, y'all, but this could lead to permanent damage. Now look at maternal risk. Traumatic delivery leading to excessive bleeding, bruised bladder, extension of the episiotomy, rectal tear, torn cervix, and or the uterus. But y'all, when you look at these risks here, your risk to your mom and to the fetus, okay, this can be a very catastrophic event to our mom and baby. So let's try to identify who's at risk. Those are your LGA babies, those macrosomia infants, the greater than 4,000 grams, gestational diabetics, previous history of a shoulder dystocia, and a post-date delivery. Y'all simply put there, that's a larger baby, isn't it, post-date delivery. Nursing care, McRoberts maneuvers. The nurse pulls those maternal legs to a hyperextended position there. And the Mazzanti technique, apply suprapubic pressure to assist in easing that shoulder past the symphysis pubis. But remember this, never apply fundal pressure. The doctor must do this or has to call another doctor. Now, I also want to mention to you about Group B strep. You don't have to write this down, just listen. GBS, Group B strep, this is the leading cause here of neonatal morbidity. That's why we want to go over this with you. It's very important. GBS risk is routinely assessed during pregnancy. It's cultured around 35 to 37 weeks, and many places can actually screen on admission to labor and delivery called a rapid GBS screen. You see, the problem with GBS is that you can be negative at one screening and positive a few months later when a second screen's done. But the key here is transmission can occur to the infant from the birth canal during delivery. But this is only a potential risk to the fetus after the membranes have ruptured. After the membranes have ruptured. Because before then, y'all, there is no portal of entry there when the membranes are intact. So teaching-wise, it's important that your patient understand, hey, GBS is not an STD. It is not a sexually transmitted disease. Also, risk factors for neonatal group B strep or GBS. Y'all, these are listed there for you. Preterm birth less than 37 weeks, positive prenatal cultures in a current pregnancy, premature rupture of membranes longer than 18 hours there, positive history for early onset neonatal GBS, intrapartum maternal fever higher than 100.4, or previous infant with group B strep positive culture. Well, let's look at what we do for this. Prophylactic antibiotic therapy. Penicillin is the drug of choice here. And if allergic, then clindamycin. And if no culture is available, unknown GBS status, all right, patient is given antibiotic therapy also. Okay, that ends complications of maternity.